Welcome to Section 3. In this section, we will be discussing how to manage an emergency scene. Emergencies can take many forms, for example, fire, bomb scare, explosion, spillage, release of toxins, to name a few. Your employer will have plans to deal with all possible emergencies that can occur at your workplace. These plans will have been discussed with you during your induction training, and it will also be posted on notice boards. These plans rely on the employees to act in a certain manner during an emergency, to ensure that no one else is injured or killed during these situations. The plan of action should firstly consider the self-sufficiency of the enterprise, and the extent to which outside sources of help, for example, fire and police departments and hospitals, may be required. In widespread emergency situations, regular supplies and equipment may not be immediately available, or may be in short supply. The community services may not be able to cope. Emphasis in any emergency should therefore first be placed on self-help, and thereafter, the assistance of the relevant authorities should be sought. Coping with an emergency. All available manpower and resources to cope with an emergency, and thus to keep essential services running smoothly, is needed during an emergency situation. How to alert the emergency medical services. Alerting the emergency services, or telephoning for the fire brigade during a crisis situation, can turn out to be an overly complex procedure, unless a pre-plan is made, as to how you go about reporting the necessary facts and information. By making use of a systematic approach, the information can be reported in a to-the-point manner, without wasting any time, or causing any further confusion, which enviably is present during emergency situations. As a first aider, you must know your local emergency department's number, and have it clearly marked on all telephones at work and at home. The emergency call. Call for help. If somebody arrives to assist you, ask him or her the following. Do you understand Afrikaans or English? Do you know anything about first aid? Please phone the emergency services on 10177, or 112 or 107. As soon as you get through to the EMS, state your name and the telephone number from where you are calling. Then supply the reason for calling, i.e., CPR, choking, etc. Supply exact address, including suburb with landmarks, and nearest crossroads. Report any complication of location, i.e., quote gate number in larger factories, etc. Find out and record operator's name, and ask the operator to repeat the address, so you know that he knows where to send the ambulance. Never replace the receiver of the telephone first, always wait for the operator to end off, as this will ensure the rapid response and arrival of the ambulance. Do you understand? What is the number? Are you able to make the call? Come back to me and report. Please hurry. If nobody arrives to assist you, you must carry out the above procedures by yourself. The emergency service could be contacted on the following numbers. Remember, the patient should never be left alone. When the ambulance arrives, the first aider informs the person in charge what has been done. Give his name and address if it is required, and only then leave the scene of the accident. The first aider should protect him or herself from injury and death, since an injured or dead first aider is useless to any emergency situation or patient. In order to prevent a mishap, the first aider must always remember to first observe the scene, to determine if danger exists, and if additional help is needed, before attempting to help. First and foremost, identify the presence of hazards. Then identify, if possible, the cause of the emergency, and the immediate environmental dangers. Are you as a first aider trained, and able to handle the particular hazards that are found on the scene? If not, the first aider must call for the appropriate trained personnel to deal with the problem. Remember, the first aider should never endanger themselves. The following are possible hazards that may be encountered in the field. Fire or the potential of the fire. Hazardous materials, like chemicals and gases. Traffic. Weather. Hostile bystanders, for example, riots and other similar situations. And electricity in a dangerous capacity, for example a leakage. Triage. Triage principles refer to prioritization of patients for medical treatment. In other words, it means the process of prioritizing sick or injured people for treatment according to the seriousness of the condition or injury. Triage is the medical screening of patients according to their need for treatment and the resources available. It applies to mass casualty situations when conventional standards of medical care cannot be delivered to all victims. The treatment must be consistent for all casualties, and the condition must be monitored and treated accordingly. Sorting of patients on a scene. In adults, priority for treatment is based on rapid assessment of level of consciousness and vital signs. As a first aider, you will assess the victims one by one and identify vital signs to give you an indication of the degree of urgency for treatment. You will then prioritize the urgency, according to the level of seriousness of the injured person. The first aider should distinguish between injured patients that walk or sit and patients that are lying down. The first aider should assess continuously while sorting the patients and delegate tasks to others. That way he can determine if a person's condition deteriorates. The injured person will then be moved to another, or higher group. Group 1 to 4. Group 1, these injured persons have life-threatening injuries such as cardiac arrest, respiratory problems, serious bleeding, amputations, open chest injuries, serious head injuries, and should get immediate attention. Group 2, these injured persons have serious but not life-threatening injuries, for example, head injuries, multiple or large fractures, neck and spinal injuries. Group 3, the injured persons have light injuries, for example, burns, small fractures, wounds, and shock, but do not need immediate attention. Group 4, these persons are deceased. The scene. Location of emergency, for example, residential or rural areas. Exact address, or landmarks and crossroads. Location of the victim, for example, trapped in vehicle. Associated complications that will need special equipment. Plan. Whom to call for help? What to say? Emergency rules. The following rules are not negotiable. Safety for yourself, the patient, and the environment. Always stay calm. Do not move the patient, unless his life is in immediate danger. Do not leave the patient alone unnecessary. Do not give the patient anything to eat, drink, or smoke. Assessing the scene. Stand still. Is it safe? Follow the emergency rules. Think. What happened? Sources of information and help. Classification of emergencies. Medical. The problem is within the body and is associated with illness. Trauma. The problem arises from outside the body and is usually associated with injuries. The mechanism of injury will determine the manpower and equipment, for example, jaws of life, needed to deal with the emergency. Information. Information will be primarily obtained from the patient. Other sources are bystanders, friends, or family. It can be based on physical evidence on the scene by using your senses, for example, smell, hear, feel, see, and taste, especially if the patient cannot cooperate, for example, age or is unconscious. Safety. It is most important to survey the scene for any possible danger, and to correct life-threatening situations. This must be done in a speedy, calm, and systematic manner, as hazards can take different forms, for example. Safety for yourself. Ensure that you have the necessary protective equipment with you, for example, gloves, life aid, etc. Safety of the patient. Only move the patient if his or her life is in danger. Safety of the situation. And safety of the area. Ensure that circumstances are safe by removing hazards and potential dangers or by evacuating the scene of the emergency. If you ever find yourself in an emergency situation, where someone is ill or injured, then you will need to perform a primary survey. On arrival, first aiders should follow the procedure below. Take charge of the situation. Call to attract the attention of bystanders. Assess hazards by establishing cause of accidents, and secondary causes of the result of the accident. Identify yourself as a first aider and offer help. Before attending to the patient of any emergency, you must first survey the scene, to ensure your safety. If you as the first aider is injured or killed, you cannot render assistance. If you as the first aider is contaminated with infected blood, you can die of a disease. No injured person should be moved if his or her life is not in danger. If a person is not breathing and has no pulse, his or her life is in danger. Life-threatening situations exist, where there is significant risk of loss of life, for example, people that are trapped in a burning car or a child that is drowning. All hazards, influencing the safety of the first aider and injured, must be removed before assistance can be rendered. Ensure that you have the necessary protective equipment with you, for example latex surgical gloves and a barrier device. Check the patient. After determining that the scene is safe, do a primary examination. This refers to a quick assessment to life-threatening conditions. Responses. Determine the level of consciousness of the injured, by looking and listening. Look for body movement, and listen for noises made by the injured. The initial primary survey is a quick way to assess patients. It can easily be remembered by the letters HHHCAB. The first H stands for hazards. The second height stands for hello. The third H stands for help. C is for circulation. This is when we check for a pulse and excessive arterial bleeding. A is for airway. We check if the patient's airway is open, maintained, and protected. B is for breathing. We check if the patient is breathing normally. If the patient is not breathing or gasping, and the patient does not have a pulse, start with CPR immediately. If the patient is breathing abnormally and has a pulse, start with rescue breaths. If the patient is breathing normally and has a pulse, check for the following. Circulation. Look for obvious open fractures and burns, and treat these injuries first. Airway. Do a log roll or recovery position, to protect and maintain the patient's airway. If you ever find yourself in an emergency situation, then all you need to remember is HHHCAB, and you will be able to systematically assess your patient, and decide what to do.
Right, I arrive at my scene, I check what happened, I gather information from the bystanders, what happened, when did it happen, how did it happen. If it is trauma, I ask the patient to lie still. In this case, this is a non-trauma or a medical patient. So I approach my patient. Good day, ma'am. My name is Nikki. I'm first aid qualified. What is your name? Matapelo. Can you tell me what happened? You're not feeling well. Right. Hazards and hello has been done. So I ask my bystanders, sir, can you please phone 112 for me? Tell them I've got an adult female that is not feeling well. Give them the location and report back to me. Do you understand?
Yes, I do.
Please bring me a first aid kit as well.
I will.
Right. Matapelo, you're obviously speaking to me. Your airway is open. Can you take a nice deep breath in for me and out? And out. Any pain on that?
No.
Right. So the airway is open, the breathing is checked, and then we're just going to quickly check for any life-threatening bleeding around the patient.
Now that you know the patient's basic observations and condition, you have more time to thoroughly examine a conscious patient, by systematically looking and feeling. The secondary survey is the practical management of injuries, in the order of priority, as detected or medical conditions. Conduct a head-to-toe secondary examination. Remember to be sensitive to the age, sex, and culture of the patient. Start the secondary examination by informing the patient of what you are going to do, and the reason for doing the examination. Listen carefully to what the patient tells you, while doing your examination. Check for any abnormal fluids, numbness or tingling, and abnormal sounds. Also remember to check for medical alert bracelets or necklaces. Pay attention to the history of the patient and incident. The acronym SAMPLE can be used for this. S stands for signs and symptoms. Which signs do you see, and which symptoms does the patient have? A is for allergies. What is the patient allergic to? Is the patient struggling to breathe because of something they ate? M is for medication. Which medication is the patient currently taking? Is the patient feeling ill because he forgot to take his medication this morning? P is for past illnesses. Does the patient have any chronic conditions, like high blood pressure or diabetes? L is for the last time the patient ate or drank. Is the patient maybe feeling dizzy because they have not eaten today? E is for event. What happened, where and when did it happen? A good tool to remember the signs of injury is dots, when you look and feel during your secondary examination. D stands for deformity. Do you see any deformities on the body? If you are unsure, compare the two sides of the body with each other. O is for open wounds. Look for any open wounds or bleeding. T is for tenderness. The patient will tell you if the location is tender to touch. S is for swelling. Look for any swelling on bruising on the body. After immediate threats to life have been removed, a secondary examination is necessary. This is a systematic examination starting from the head down to the lower limbs, as follows. Temperature. Feel the forehead and the back of the neck, to see if the skin temperature is much warmer or cooler than that of your hand. Pulse. Check the pulse, noting its rate, strength, and rhythm. Breathing. Note the rate, rhythm and depth, and smell the breath for distinctive odors of chemicals, or acetone. Eyes. Note if the pupils are fully dilated, constricted, or of unequal size, and then check for reaction to light. Ears and nose. Look for any blood and other fluid discharge that may indicate skull injuries. Mouth. Check the mouth for fluids or vomitus that might affect breathing. Also check for false teeth if the casualty is unconscious. Skin. Note the color, the amount of perspiration, and the temperature. Skull. Check for bruises, bumps or bleeding that may indicate head injuries. Neck. Check the neck gently. If there is pain or a deformity, suspect a fracture of the spine at the neck. Spine. Feel along the center line of the back for irregularities. If there is bleeding, you feel an area that is warm and wet, or if there is tenderness and pain, suspect a fracture of the spine. Chest area. Look for wounds, and note any unnatural movement of the chest. Gently feel the ribs with the fingertips for irregularities or, if the casualty is conscious, ask him to take a deep breath and cough. Pain and tenderness indicate a possible fracture of the ribs or sternum. Abdominal area. Look for wounds and bleeding, and ask the casualty to pull in and push out their abdomen. Suspect internal injuries if this causes pain. Pelvic area. Gently feel on either side of the hips for signs of tenderness or irregularities that might indicate a fracture of the pelvis or dislocation of the hip. Lower and upper limbs. Check the limbs for irregularities in the long bones or joints. To assess for nerve injury and loss of power, ask the casualty if he is feeling in the fingers and toes, and if he can move his limbs. After checking the patient, call the emergency services, and give them a description of the emergency, as well as the location of the scene. After calling the emergency services, provide appropriate care, based on your primary survey of the patient, until emergency services or other advanced medical personnel arrives and takes over. The following acronyms can be used when handing a patient over to a person with a higher medical qualification. These acronyms help us to remember which information is important. For a medical patient, remember NIS. N stands for the nature of the illness. I stand for which illness does the patient have. S stands for signs you can see and symptoms that the patient may have. T is for which treatment did you provide to the patient. T is for the time the incident happened. For a trauma patient, remember MIT. M stands for the mechanism of injury. How and what injured the patient. I stands for injuries. What injuries did the patient obtain? S stands for the signs you can see and the symptoms the patient is feeling. T stands for the treatment that you have provided to the patient. T stands for the time the incident or accident happened.
We are going to be performing the secondary survey now. Now, hazards and know-how, circulation, airway and breathing has been done. We are going to be looking now for any other injuries using dots, deformities, open wounds, tenderness or swelling. Now, I want to reiterate, if possible, if I have a female patient, let it be a female that does the secondary survey. If it's a male patient, preferably a male first aider. Right, when we do the secondary survey, we do a head to toe. So we start at the head. First thing that we do, always close your fingers and feel for any dots. Feel on top of the head and feel around the eyes. If the patient is awake, ask them to close their eyes and then to open it again, checking for the pupil reactions. From there, we check the nose and we check inside the nose if there's any blood. From there, we can check inside the ears and at the back of the ears just to see if there's any fluids or any bruising behind the ears. From there, we feel the upper and lower jaw. We can ask the patient if she's awake to open her mouth, check if all the teeth are in place and not broken, and also check for any blood or vomit inside the mouth. You can relax, thank you very much. From there, we go down to the neck. We look for any distended neck veins or a deviated trachea. Or you can even look for a medical alert necklace. From there, we go to the shoulders. Remember, closed fingers. First things that we feel is the collarbones. Just press slightly down, not too hard. You will feel movement if there's a problem. Okay. From there, we feel if the shoulder is in place. Look at your patient's response. If there's any pain, she will frown or tell you. We go down to the upper arm. Just feel slightly, putting your hands in this position and just squeezing towards each other slightly. Please don't press too hard, because if there's a fracture, you might make it worse. If you don't suspect any injuries on the elbow, you can ask the patient if they can bend the elbow, and then also the lower arm. If you get to the lower arm, feel if there's a pulse present. We check the hand, each and every finger. Okay. Also remember to check inside the hand and to check capillary refill. What we do on the one side, we do on the other side. Now, if your patient is awake, Matapelo, can you take a deep breath in for me? Can you breathe out? Any pain on that?
No.
Okay. If the patient does say that there's any pain, we expose. Remember to try and keep it as private as possible. And we check for any injuries on the chest. You can also feel by just placing your hands inward and pressing slightly inwards to feel if there's any broken bones. And you must feel the sternum. Now please never place your hand like this on a female. Your hands must always show downwards. Right. Then we go down to the abdomen. You take your strongest hand, you put it at the bottom, and your weakest hand on top. And you just gently squeeze in, and you move in 4 quadrants of the stomach or abdomen, looking for any response from the patient. At the pelvis, all we do is just place our hands in the side and press towards each other, just to feel if there's any instability. Please do not press on top of the hips. From there, we go to the upper legs, and we do the same as with the arms, gently squeezing towards each other. At the knee, you will feel the knee. This is a bone that moves. Okay. If it is stuck, it usually means that there is a problem. We go down to the lower knee, of the lower leg. Right? You can remove the shoes, it's not a problem. And then we can feel if the toes are moving. Matapelo, can you move your toes for me? Very good. Any pain on that?
No.
Okay. If I, like the bottom of your shoe, can you feel that?
Yes.
Very good. And if you remove the shoe, remember to check for capillary refill. What you do on the one side, you do on the other side.
Measuring a person's level of consciousness. Changes in the level of consciousness of a person who may have sustained an injury to the head are an important sign of the way the brain is functioning. The scale used to measure this is commonly called AFPU. See the following page for details. The head-to-toe survey of the injured patient. Management. Life over limb. Control bleeding, cool burn wounds, immobilize fractures. The head and neck. Control bleeding and cover wounds. The chest. Control bleeding and cover wounds. Close any sucking open chest wound, which will be discussed later. Stabilize impaled objects and cover wounds. The stomach. Control bleeding and cover wounds. The extremities. Control bleeding with direct or indirect pressure and cover wounds. Position the patient. Cavities gets preference over extremities. If a cavity is injured, position the patient onto injured side. If extremities are injured, position onto uninjured side. Reassure and maintain body temperature. Monitor the vital signs every 5 to 10 minutes until EMS takes over. Injuries. There are 3 injuries that take precedence over the rest, and emergency services should be called if the patient has sustained injuries to the head, neck or back. The patient is having trouble breathing. The patient is unable to move or use the injured body part without experiencing pain. These require special and careful attention. Information needed to determine the casualties, injuries or illnesses grouped under 3 headings and defined as follows. History. Events leading to emergency situations, accidents or violence. Signs. Conditions you can see that indicate disease or injury, for example, body temperature, pulse, breathing patterns commonly named as the vital signs. Symptoms. The sensation the person feels as a result of the injury or illness, i.e., cold, pain, nausea, numbness, etc. Monitoring the patient. Vital signs and symptoms. It is especially important to monitor the patient, as the condition of the patient can change very rapidly. It is often particularly useful to provide the paramedics with a record of the patient's condition. It is for these reasons that the following signs and symptoms be monitored regularly, approximately every 5 minutes. Level of consciousness, also known as AFPU. The breathing rate. Circulation, especially pulse rate. Skin color. And skin temperature. Monitor casualty and treat according to vital signs and condition. There are different signs that a first aider should be aware of. These signs are stressed in order to monitor the condition of the injured person. The pupils. Shine a flashlight or headlamp into the injured person's eyes. Note whether the pupils contract symmetrically when exposed to the light. If the pupils are unequal in size, then it may be a sign that the person is using drugs. Look out for these warning signs, because you can save a life. Blood circulation or capillary refill. This is usually done on the nail beds of a patient. This can be done on the fingers or toes. If the white area does not turn pink within 2 seconds, this may indicate that oxygen-rich blood is not circulating properly. Blood will return to a healthy person's capillaries in less than 2 seconds, changing the color of the pressed spot from white to pink. Checking for a pulse. The pulse is checked with the index and middle fingertips by gently pushing down onto an artery. There are 3 ways in which a pulse can be measured, namely, carotid pulse. This being the preferred method for checking adults and children. The pulse is checked on the carotid artery in the patient's neck between the neck muscle and the trachea, also known as the air pipe. Radial pulse. This is checked on the palm side of the wrist, above the thumb. Brachial pulse. This is the most reliable and most easily found in infant, located in the inside of upper arm. Femoral pulse. Located in the thigh, halfway between the pubic symphysis and anterior superior iliac spine. Popliteal pulse. Above the knee in the popliteal nasal, found by holding the bent knee. The patient bends the knee at approximately 124 degrees, and the physician holds it in both hands to find the popliteal artery in the pit behind the knee. Dorsalis pedis pulse. Located on top of the foot. Temporal pulse. Located on the temple directly in front of the ear. Never use your thumb to feel for a pulse, as the thumb has a pulse of its own. Do not feel or compress both carotid arteries at the same time. This could affect blood supply to the brain and cause severe damage. Feel for the pulse for 10 seconds. If the pulse is present but the patient is still not breathing, continue artificial respiration at the rate of 1 ventilation every 6 seconds. This is also known as rescue breathing. If there is no pulse, begin CPR immediately. Important to remember that the pulse rate is respective of the age of the patient. Adults have a pulse rate of 60 to 100 beats per minute. Children have a pulse rate of 100 to 120 beats per minute. Infant up to 1 year, a pulse rate of 110 to 160 beats per minute. Skin appearance. The appearance of the skin can be a good indicator of the patient's condition. Check color, condition, and temperature of the skin. The color of the skin. Check the color of skin in the mouth and lips. Red, pink, pale or blue. Checking the lining of the mouth and lips allows a quick assessment of patients from all ethnic backgrounds. The temperature of the skin. Is the skin warm or cool to touch? The skin condition. Is the skin dry or wet? Breathing or respiration. The respiratory rate is the number of breaths a person takes per minute. The rate is usually measured when a person is at rest and involves counting the number of breaths for 1 minute. This is often done by counting how many times the chest rises. To save time, this can be done over 30 seconds and then the result doubled. However, this is a less accurate method. Respiratory rates may increase with fever, illness, and with other medical conditions. For example, an asthma attack is likely to significantly increase the respiratory rate. When checking respiratory rate, it is important to also note whether a person has any difficulty breathing, or if there are any sounds during breathing, for example, a wheeze. Normal respiratory rates for an adult person at rest range from 12 to 20 breaths per minute. Children have faster respiratory rates. An effective way to take a respiratory rate is to combine it with taking the pulse rate. Explain to the person that you are going to take their pulse for a minute. Count the pulse for the first 30 seconds, and then count the respiratory rate for the second 30 seconds. This avoids the person changing their breathing pattern subconsciously. The breathing rates are as follows. Adults, 12 to 20 breaths a minute. Children, 5 to 12 years, 20 to 25 breaths a minute. Children, 2 to 5 years, 25 to 30 breaths a minute. Children, 1 to 2 years, 25 to 35 breaths a minute. Infant up to 1 year, 30 to 40 breaths a minute. Let us recap the summary of emergency treatment sequence. Number 1. Safety of your patient and yourself is of first concern. Check areas for hazardous and safety elements. Number 2. Breathing. Is the patient's airway clear? Number 3. Pulse. Is CPR needed? Number 4. Symptoms. Does the patient experience any pain? Number 5. Bleeding. Treat any bleeding and cover wounds. Number 6. Breaks. Attend to fractures and immobilize them. Number 7. Transport. Get your patient ready for transport to hospital. Number 8. Observation. Watch patient's respiration, pulse, and movements.